I'm going to go ahead and get started. Thank you all for joining us here. My name is Jessica Baez. I am an assistant program director at the University of Cincinnati, and it is my honor to introduce this topic on behalf of a wonderful team that I have here with me, where we're going to be talking about development of a clinical skills training framework for emergency medicine faculty members. We have no financial disclosures, and our hope is that by the end of this talk, you will be able to evaluate different faculty development models to determine which may be most effective for your specific faculty group. We're going to have you describe kind of factors that can motivate or hinder your faculty from participation in these sessions. And through our small group session, we're going to hope that you can generate some ideas on how to execute some targeted clinical skills sessions for your specific faculty. Now, as emergency medicine physicians, we all recognize that our job involves life and death scenarios, and our roles means that we have to be ready for anything at any time. Oftentimes, as faculty, we are then tasked with performing or supervising potentially procedures or clinical skills that maybe we don't have personal experience with. We've learned things in simulation, but maybe have never done it at the bedside. I think transvenous pacer is a great example of this, where it's a potentially life-saving procedure that is performed quite uncommonly, and we have to be prepared to place this at any moment when a patient needs it. Outside of clinical or procedural skills, there are a variety of clinical scenarios like neonatal resuscitation that are high acuity, low occurrence, and it really requires us to act decisively and correctly for our patients in order to really shape a patient's potential life or future. Beyond this, emergency medicine itself is also a constantly evolving field with new technologies and new advancements and evidence being released all the time. I think ultrasound is a great example of this, where 10 years ago when I started residency, the application of ultrasound was quite variable across institutions, and now it's ubiquitous in emergency medicine, and there are constantly new technologies being released and used in the emergency department. And through all of this, it's often very challenging for us to keep up with all of the kind of different skills that we need to in a field that requires such a breadth of knowledge. And it turns out really that clinical practice alone is insufficient for sustained proficiency in all of these skills. And there's plenty of evidence to suggest that deliberate practice of your clinical and procedural skills is really necessary to master all of these skills. There was one study looking at a needs assessment of 56 faculty members at an academic institution, and they found that 96% of those faculty members acknowledged that skill attrition is a problem within our field. 78% of them acknowledged they personally had experienced skill attrition in their own practice. And the overwhelming majority were interested in participating in a clinical skills development program at their institution. And this is the perfect opportunity where we really have an opportunity to intervene upon a kind of this natural decay that occurs in our skills after we graduate from residency. We're no longer inundated with education necessarily, and we have this natural skill attrition that occurs. And if you implement a refresher training of sorts, you can potentially kind of overcome this and help achieve sustained mastery. That being said, I think that we can all acknowledge that achieving, assuring, and maintaining competency, it comes at a cost in terms of our time and our efforts and our overall kind of ability and perseverance, both to the individuals participating, but in the departments and the systems that are creating this as well. And so our hope is that with this discussion, we can provide some tips and some ideas on how to create a sustained and successful faculty development program for your institution. So through this, we're going to present the approach to faculty development at 3 different institutions: Penn State, University of Cincinnati, and Washington University in St. Louis. So first up, I would like to introduce Dr. Susan Promise, Chair of the Department of Emergency Medicine at Penn State.
Thank you so much. I'm delighted to be here today. This topic is near and dear to my heart. I've been a chair of emergency medicine. In July, it'll be 11 years. I was excited to take on that role, but one of the things I rapidly learned was my job administratively overseeing the faculty for their clinical privileges. That I had to sign on the bottom line when I hired a new faculty member, or every couple years when their privileges got renewed, that they could do a list of tasks that were procedural skills. And frankly, when I was new, I didn't really know any of the faculty. I had no idea what their competency level was, what their experience was of procedural skills. Our institution has now instituted a process that I literally have to look at a list of procedures that people have performed before I sign off on privileges every couple years to renew people's privileges. And when we all went into medicine, right, this is a premise we're all about. First, do no harm. I want to share with you a story. I hope this stays in this room. I'm going to share a couple stories. And the first story was of a patient who was sent to the emergency department from our oncologist. The patient had just had a MRI. I forget what the MRI was for, but incidentally on the MRI, they found that the patient had a large pericardial effusion. So they said, as soon as the radiologist looked at it, they said, you need to go directly to the emergency department. This was an example, not this patient's echo, but an example. The patient comes in, and our emergency medicine senior resident was super excited. They were going to get to do a pericardiocentesis. That was really cool for them because they've only ever learned about them, practiced them in simulation. And our faculty member wanted to make sure this graduating resident had the opportunity to do this procedure. Well, we got a new kit in our emergency department, and this was the one they were going to use to put the catheter in. It has a trocar, not specifically this one, but it was a trocar kit. And unfortunately, that catheter, the resident had a really hard time putting it in, so the attending took over. The attending had never used the kit. The patient had a trocar go through the myocardium. The patient did not do well. The surgeon was called. There was a long delay. The patient finally went to the OR, and you can guess what the outcome is. So then I got to deal with this. Not only did I have to go disclose to the family that there was a medical error and the patient unfortunately did not survive, but then I had a faculty member who was devastated, and a resident who was really up in arms. And then it led to the Department of Health coming because we had an unexpected death. We had to do a RCA, which went on for quite some time. So it made me pause and say, oh my gosh, we got to do something different. Like, this is not good all the way around, right? We're here to do no harm for our patients, but we got to care about our team. And as the chairman of the department, I was like, accidents happen, but when a person's life's at risk, this is a big deal. Fast forward a few years, this is my case. I was caring for a patient who had really bad pulmonary disease, had multiple blebs, our interventional pulmonologist had been dealing with this patient, came in extremely short of breath. We got an x-ray. The patient had an obvious, huge pneumothorax. And in our ED, it was lots of history here, but I had to call another service. And I said, hey, we have your patient here. I need you to come down immediately. They need a chest tube. And if you're not here, we're going to do it. The person came down rapidly. It was a fellow, but the fellow forgot to share with me he'd never really put in a chest tube. He'd done pigtails, and he was walking out of the room to go call someone else. In the meantime, the patient went into tension physiology, got a needle decompression, etc. So I said to myself, I had to go through that whole process. I felt horrible, but I was the chair of the department. I was going to follow our processes. And I said, we got to do some things different. So we implemented, for all new faculty that come on board, they get oriented to our equipment. We have a team of people. Somebody does airway, other people show our ultrasound, but we wanted to make sure that people knew the critical things you had to do. Where are things in our institution? How do you get through them? And then we instituted quarterly faculty development sessions led by my vice chair for faculty affairs with input from the team. And anytime we get new equipment, the goal is to have people now sign off that they understand the equipment and how to use it. So that's my story. You'll hear a few more down the road. Thanks for listening.
Hi, my name is Elizabeth Lee Nellett. I'm the Vice Chair of Academic Affairs at the University of Cincinnati. So our group is comprised of about 65 plus attendings, as well as about 35 APPs plus our residency, who practice at the main academic center as well as two community sites. And we meet every month for about 2 hours at our monthly faculty meeting, other than in May and in December where we have our faculty retreats. And traditionally, the agenda was centered around section reports, pressing issues like patient throughput or recruitment updates. Educational sessions were kind of ad hoc, usually in response to the addition of new technology, clinical pathways, or ACGME requirements. But like many during the height of COVID in 2020, we were facing a lot of issues of low morale and burnout. And it seemed like a really good time to put our finger on the departmental pulse and potentially make some significant changes with the culture of our ED survey, which was actually initiated by Dr. Settler in the back. It addressed all of the facets of our department, including the clinical, administration, leadership, and attitude or the culture of our faculty. It highlighted our strengths as well as our areas of opportunity. And not to our surprise, lack of mentorship ranked number 3, and the need for a robust faculty development program ranked number 5. So we wanted to align all of the departmental efforts, and as a result, we created or reinvigorated a faculty development committee open to all faculty members to create an overall plan. And so this included curriculum planning, covering ACGME topics, initiating a mentorship program, and generating other ideas, since faculty development meant so many things to different people. Whereas some, it was the soft skills of leadership and emotional intelligence and communication, whereas for others, it was all about obtaining clinical skills. Just as importantly, we started labeling all of our efforts as faculty development on agendas as well as meeting minutes, and we created a dashboard of our initiatives. At our faculty retreat, we discussed the results, prioritized our needs, and brainstormed ideas that led to clinical quick hits, which are 10 to 15-minute didactics led by either volunteer faculty member or guest lecturers from other departments, and the concept for high acuity, low occurrence procedural skills training. So here's a snapshot of some of our clinical skill sessions. Some of our faculty repeated skill sessions in order to get hands-on experience repetitively, which is the reason why some of those totals are greater than 100%. And given the popularity of these sessions and the feedback that more practice with Halo sessions would be appreciated, we decided to make this an annual Halo session event. And we handed over the baton to the educational committee to actually operationalize these sessions. And I'm happy to report that in the most recent 2024 iteration of the Culture of the ED survey, faculty development has actually emerged as one of our greatest strengths. Speaking of handing over the baton.
And my name's Erin McDonough. I'm the residency program director at the University of Cincinnati. And I'm just going to spend a few moments talking a little bit more about the Halo workshops that we did and kind of logistics and that sort of thing. This has definitely evolved over a number of years. And topic selection was actually very intentional. We considered topics generally based on whether or not we had experienced a quality issue similar to what Dr. Promise talked about earlier. Or was there a procedure that we were at risk of losing ownership of to another service? Or were we falling short on resident education goals? Those were all kind of different motivations by which we selected these topics. And initially, we offered them voluntarily, just kind of as an aside in faculty meetings and retreats that faculty could partake in or not. And they were pretty well received, but obviously had certainly a minority of faculty taking advantage of that. And so then we actually made things more formalized this past year. We have made our sessions mandatory. We decided to focus on one topic per year and make it something that the faculty had to partake in over the course of that year. We chose kind of timing and such to meet faculty needs, it made it such that faculty had to do this. The topic that we chose for this past year was transvenous pacer placement. Dr. Baez had created a very nice model for that. And it started with an educational, like an asynchronous educational module that we had posted on our educational blog, Taming the Shrew. And then after that, hands-on sessions. And these were the most obviously time-intensive, resource-intensive components of the Halo procedure workshop. Given we really tried to meet the faculty where they were as far as providing flexibility. So we offered a number of sessions over the course of the year, about 2 per month, with one being immediately following our monthly faculty meeting and another following grand round, so that faculty could, make 2 trips into the offices at the and achieve multiple goals with that. And with having that many sessions, we needed a pool of faculty volunteers to lead them. And so we started with a couple of train the trainer sessions to train faculty volunteers and have a pool of people who would be willing to serve as instructors at these sessions to spread some of the administrative time burden of doing these. Dr. Baez really kind of set a standard that we're continuing as far as creating an instructor manual for these. You're having train the trainer sessions in the spring and then offering these sessions all throughout the year. So she created a guide that really was a step-by-step, how do you set this model up, how do you set the workshop up, and then a step-by-step of the procedure so that trainers who went through the training in the spring were then able to refresh themselves before teaching a session, say in March. And this worked very well, and the sessions were well received. We also added some incentive to this for this time. I mean, making something mandatory for faculty to complete is a big lift for department leadership to ensure compliance and that everyone achieves it. So we opted kind of for both a carrot and stick approach. The carrot being that we applied for CME so that we could offer CME to faculty in these sessions, and the stick being that we did tie it to our variable compensation. Traditionally, our variable compensation bonus had really been kind of a guaranteed part of income for our faculty, but our institution has really been pushing over the last few years to make these more incentive-based. And so we were able to kind of align with that goal by the institution to make part of faculty's variable compensation dependent on completing this session. And again, not a lot to ask. You're spending a couple of hours once over the course of the year to learn or retrain yourself on a skill that we should be able to do but don't do very often. And these were very well received. We did some pre and post surveys that showed that faculty really found them to be high yield. Anecdotally, a couple of faculty came up to me and told me that they had to place a transvenous pacer in the emergency department relatively soon after going through one of these workshops, and that it made them feel much more comfortable in doing so, which is the goal. So we're going to continue this model for the next academic year, including offering CME and tying it to our bonus structure, with this year targeting cricothyrotomy, given the importance of that procedure. I still have never performed one and hope never to do so, but I still need to practice doing it in case I have to. And then we are also going to, at the same time, have a subclavian line placement, given that that's an important crash line that in the era of ultrasound, people tend to be more inclined to trend towards ultrasound guided IJ placement as opposed to subclavian. So that is the Cincinnati approach currently.
Thank you. I'm Robbie Paulson. I'm the Vice Chair for Faculty Development and Mentorship at WashU in St. Louis. And I'm here with my partner, Doug Char, right over there. And I'm happy to present our faculty development model to you as just a third flavor for you guys to choose from. So we've had emergency medicine at WashU for a long time. The residency program started in 1997. We are a young academic department, and so we gained department status in 2021. And as a result, positions like Vice Chair of Faculty Development did not exist because there was no chair for which to have vice chairs, right? So my position here is relatively new. Prior to becoming a department, there was ad hoc faculty development, as you can see with a lot of these models, where you often have one person where it's their passion, and with their energy, and that's Dr. Shander Aubin right there, they run the show. And if they have the time, they have the bandwidth, or a case comes up where you say, here's a training opportunity, they do it. But there was nothing really formalized. So as our department kicked off and we wanted to be intentional about this, a task force was formed along with Dr. Char, Ruben Johnson, and my partner, Joe Noker. And that task force really started to think about their why. What are the guiding principles of faculty development? And first and foremost, we wanted to build a department culture through faculty development as a tool. And that starts off with a culture of humility. And as faculty, you face a lot of pressure for having to be experts, but at the same time, you need to know your own limitations. You need to know what you know and what you can do better. And we wanted to normalize an environment where that routine training was expected and encouraged in a safe manner. There's a difference between maintaining competence as well as the pursuit of mastery. And it's not just with our clinical skill, but also how we function as educators in an academic emergency medicine department. And then lastly, our program, we didn't want it to just be about the clinical skills, although again, that's why we're all here, is to take care of patients. We also wanted to intertwine intentional professional development into our curricular structure. So that led to two overarching goals, the first of which was more knowledge and skill-based, so maintaining and enhancing knowledge in the daily practice of emergency medicine, whether that's patient care at the bedside or our educational skills. But we really wanted to have that hidden curriculum of cultural norming, in which we foster an environment where regular and voluntary participation in continuing medical education is the norm. So this was our department at the time. We were over 80 faculty and fellows, and also wrapped our APP group into this. We currently serve 3 clinical sites, 1 academic, and 2 additional satellite sites with a presence at Children's Hospital. So as they set off to start this curriculum, there was this focus group and a large needs assessment took place. And obviously this brings up some competing views on what we want versus what we need. Faculty wanted lots of different sessions available. Again, we have to be prepared for anything at any time, but you also have to balance that volume and that frequency with the bandwidth of your main instructors that are going to deliver that content. Again, blind spots are really tricky. People say that they want one thing, but they might need something else. And there may be some differences between what your general faculty needs versus what their leadership think that they need, or other key stakeholders within the institution. We had a key philosophical discussion about whether faculty development should be made optional or required. And this is where we actually diverged from some of the other models that you see. And I'm a movie buff, so we're gonna go Field of Dreams on this. So if you build it, they will come. This is the idea that if we build a very quality program and use word of mouth among our faculty, we're gonna get buy-in over time. That slow, steady cultural building, put out a good product, then yeah, some sessions may be kind of small, but over time that program's gonna build so that people don't come to faculty development because they have to check off a box. People don't come to faculty development because they're gonna get paid a little more, although again, sometimes incentive is at play. As we built this culture, we wanted to norm it voluntarily. And then when the day comes that you do have a session that needs to be required, our faculty are much more accepting of that because they say, oh, you know, I know what you guys are offering. This must really be important. I'm happy to come, or I hope so. So our program was built on these core tenets. So we needed variability, not just in the content that we're offering, but in addition to the educational modality, as well as the frequency that these sessions are offered. You need to be able to offer things multiple times, just like, again, you heard here, to capture your nocturnists, capture people who have a department meeting that's recurring on a specific day, to give everybody the opportunity to come. In a post-COVID landscape, we needed to leverage in-person, Zoom, as well as hybrid models to make sure that we can make the barriers to attendance very, very low. And just like you've heard from our other programs, your curriculum has to be agile. You can go into this saying, I'm gonna have this rigid repeating structure, but then just-in-time demands come up and you need to, in terms of your curricular oversight, be able to flex, and have had to do that over the last couple of years. So this is the structure that we've settled on at WashU. We have a monthly cadence and we have 3 different formats. In the first month of the quarter, we lead off with a didactic. This is often clinical, though not exclusively. It's a 60-minute time slot, and again, we're adults. We prefer discussion-based, interactive, case-based learning whenever possible. Our second month of the quarter is typically a skill. This is a 90-minute session, again, interactive, but really hands-on and thus by necessity, often in person. Again, some skills are soft, so we have used some simulation as well as video review. as well as discussion to learn some of those more communication-based or social skills. Lastly, I offer something that's a procedure lab, but I view it kind of like office hours, in college where you go and there's a TA and they're there and you can just ask questions or do your work in a corner and, kind of wave when you need help. That's what this is. So we have a HALO task trainer, so high acuity, low occurrence. We have a LALO task trainer, so something that's low acuity, low occurrence, and then often another skill, typically ultrasound based. And faculty have the option to show up and just do reps on their own, and that's totally fine. Faculty can flag down someone like me and say, hey, I haven't done this in a while, can you walk me through it? Or this is a social thing. So you can see your partner over on a task trainer, walk over and say, hey, show me some tips and tricks. How do you do this? And then people are teaching each other as peers. So it's very, free form. Again, takes a little bit of time, takes a little bit of resource, but we wanted people to feel psychologically safe in practicing these procedures and admitting what they know and don't know, having the form to practice. And again, like my partners here, we do have a quick hit format that's embedded into our faculty meeting structure. Often this is a summary of what we've covered in some way in a preceding didactic or skill session. And we also bake into some of those other professional development skills like mentorship, individualized development plans, balance, saying yes, saying no, etc. Some formats that have worked really well for us include gamification. So it's one thing to say, we gotta re-up our splinting. And it's another thing to gamify it. And we are remarkably competitive individuals. So this one was fun. Our faculty, again, want to make their time count for something. So when you're doing an ultrasound training session, making sure that someone's actually keeping track of the scans that are performed for credentialing. So again, they feel that that is time that is well spent. And we also want to make sure that the content that we present isn't just evidence-based, but is relevant for each of the environments in which we practice. So constantly trying to say, okay, this is how this works. How does this work at Barnes? How does this work at Missouri Baptist so that people have the tools that they need? I wanted to share some of our successes and challenges with the first 2 years of our implementation. So this is our data from our first 2-year cycle. So that's February 2023 to January of 2025. We had a total of 18 sessions over that time period, and you can see that the skill sessions are slightly more attended than the didactic, and I think that's expected. I think people are more likely to make time for something that's a hands-on skill. So about 28 attendees across the entire offering of that skill. So we offer each one 3 times to maximize one's ability to attend. I am an optimist, and so I'd like to say that there's an upslope to this, and I think that that's a sign of our cultural growth, where you do start to see more and more uptake over time, and at least based on chatter in the group, I do think that that's actually playing out. Another way to look at this data is to look at this by learner. So over this 2-year time period, we had data from 95 unique faculty and fellows that came through our group, and you can see the distribution of how many sessions that they attended over that. Our high attendees are instructors like myself and Dr. Char that are kind of skewing that mean. But even with us removed, our mean is about 4.7 sessions per faculty member for this 2-year period. Where I struggle as a person that's overseeing this and trying to motivate my group to come is with this statistic. So in our group, there are 29% of our faculty who have only come once. And I'm really trying to understand why and what I can do in order to help minimize those barriers. And part of this is through survey. We send a survey after every session, both to people that attended as well as people that didn't, to get feedback. And I think the overarching theme is that everybody appreciates that faculty development is there. They want to be in a department that they feel is looking out for them in their own growth as clinicians and educators. And even those that don't come say that they value what we're doing. And then when I ask them, how can I get you to come? It's often, well, I have competing obligations, and we all do. That's understandable. They've requested video recordings, and so I don't know how often they're being accessed, but we do have them. So for sessions that are, like we said, we try to emphasize Zoom or hybrid options. We'll record what we can, and we do put them on our faculty development website. That can also serve as a reference for people that may say, I remember that transvenous thing you did a while ago. I need to do this, and can access it for a just-in-time resource. Again, we're adult learners. They valued active learning opportunities as well as CME and credentialing whenever available. We've also tied our repository of content to our faculty development calendar. And so we're trying to make accessing these sessions very easy. And it ties into the WashU institutional opportunities as well, all on our department website. At the end of the day, whether it's a person that is a vice chair or a director or a champion, in order to make a program succeed, you have to have time. You have to have some financial backing. You need the authority to interface with lots of different, whether that's departments or divisions within your department. And you need a chair that believes in you and gives you a lot of freedom to build and create, and the ability to engage other members in the department, again, just to get that groundswell of cultural change and build something that's robust. For future directions, now that we've done a 2-year cycle, one of my biggest questions is when to repeat. I think that's going to be very different based off of the skill. Some skills, again, you see in the department from time to time. Others have a very rapid decay rate just because there's such low incidence, and when to do that. We've undergone a pretty massive clinical expansion. So starting July 1st, we're adding 4 additional community sites. What are their needs? And are those different in any way from those that are serving at our primary academic sites? So my solution right now is to tailor a program specifically for them. We'll see how that goes over the next few years. Again, I mentioned that our program was voluntary, and we thought one day there's going to be a need for something required, and we've actually hit that in our group now. And so we're currently requiring a coaching framework for airway management. And it's been interesting to see that, where for the last 2 years it's been voluntary. And now that they have to go, people are like, yeah, sure, I'll go. And we've gotten 86% through our first iteration just over the month of April. And so that's a total of 92 faculty and 11 fellows, all in 1 month. And so they're showing up, and they're showing up really strong. We also want to look at our clinical data just to make sure that people aren't just attending, but that they're getting something out of it, and hope to see some changes in clinical outcomes by the educational work that we're doing. And with that, I'll toss it back.
All right, for this, go ahead. Great job. All right, for the next several minutes, we're gonna kind of have you guys discuss amongst your groups here, and we'll come to your tables to talk a little bit about how you can tailor some of these ideas for your specific programs. I'm gonna have you guys answer the following questions. We'll come to you guys. Those of you in the back, would you guys mind joining tables up here so we can group discuss?
So we have just a couple minutes left if people want to just close their conversations. And I guess the one thing I want to hear, did anybody come up with something really good that we are missing? Wait, go for it.
I love being voluntold. Like you hear.
Hi, everyone. My name is Emily. So one thing we've done to try to improve engagement and culture is actually started a procedure club night. So kind of like journal club, but focused on these Halo skills. Not required, but just another way to, again, build the culture in a fun way.
Other ideas that came up at the tables. I think we talked about how hard it is, but also just how important, right, to try to get people to do it. All right, great. Thanks everybody for your engagement. Really appreciate it.